Hello everyone, welcome to another NP Academy lecture. Today we will talk about how to diagnose and treat pneumonia in adults. So we will talk about pneumonia in adults. We will discuss the cause of pneumonia, sign and symptoms, how you will make a diagnosis of pneumonia, and how you will treat them. Treatment. And we will keep the discussion focused on the outpatient treatment of pneumonia. The inpatient is a little different, so we'll talk about the outpatient treatment. Okay, well, pneumonia is rather a very broad and complicated topic. There are different classifications of pneumonia that has changed multiple times. So the one that we will talk about today is something called CAP. CAP stands for community acquired pneumonia. This is the one that patient get the pneumonia when they're away from the hospital, so in the community when they get the pneumonia, and then they come and see a healthcare provider. So this is the one that we will talk about today. There's some other classification too. There's something called HAP. HAP stands for hospital acquired pneumonia. This is the one that patient get the pneumonia when they are already in the hospital for 2 days or more than 2 days. So say for example, if you got a pancreatitis, you go to the hospital. 2 days later, while in the hospital, you got the pneumonia. So that's called HAP. The another one is called VAP. This is your ventilator associated pneumonia. And this one that the patient get the pneumonia 2 days after being intubated. So that's called VAP. We won't talk about VAP and HAP. There used to be another term called HCAP. HCAP is your healthcare associated pneumonia. And this is the pneumonia among nursing home resident. So nursing home resident, or the people who get the who are the dialysis patient, or people who have a chronic wound, or people who are on the home IV therapy, etc. And the idea at that time was that these patients are usually infected with multi-drug resistant bacteria. So they have a MDR, that stands for multi-drug resistant infection, and they need to be treated with broad spectrum antibiotic. Broad spectrum antibiotic. Well, turn out that that was not the case entirely, and a lot of these patients were getting all the big gun antibiotic like zosine and vancomycin that actually they didn't need it. So in the most recent guideline, this term HCAP is actually terminated. So HCAP does not exist anymore. Bye bye HCAP. And these patients who were the part of HCAP at the time, now we treat them like a CAP. And we look at the role of MDR infection and the need of broad spectrum antibiotic on case by case basis. Also, all the information that we will talk about today is based on the IDSA. These are your Infectious Disease Society of America, as well as ATS. This is your American Thoracic Society, and up to date, this is your peer review online platform for the healthcare provider. Okay, so with that, let's first talk about the cause of pneumonia. What causes the pneumonia? And there are over 100 microorganisms that have been associated that cause the pneumonia. And these are your bacteria, viruses, and fungus. Today, we will talk about the bacterial cause of community acquired pneumonia. We won't talk about the viral and fungal cause, those are a little bit different. So, among bacteria, this bacteria that cause the pneumonia has been divided into two main categories. The one is called typical, and the another one is called atypical. And this division is based on the gram stain. So the typical bacteria actually react to the gram stain and it become either gram positive or gram negative. On the other hand, atypical bacteria does not react to gram stain at all. So that's one of the main difference. Other difference is that it was thought at the time that if you have a pneumonia that is caused by the typical bacteria, you will have a sudden onset of fever, cough, chill, etc. On the other hand, if you have a pneumonia that is caused by atypical bacteria, you will have a more a slow progressing disease, the so-called walking pneumonia. But today that's not correct entirely. Okay, so one of the most common cause of bacterial pneumonia is your streptococcus pneumonia. Pneumonia. Streptococcus pneumonia is the number one cause of pneumonia. Okay, the fact is the disease named pneumonia actually came because the pneumonia is caused by streptococcus pneumonia bacteria, and this is your typical bacteria. Some of the other typical bacteria is your Haemophilus influenza, the so-called H flu. Just so you know, this is a virus. This is not a bacteria. At a time when this bacteria was discovered, it was thought that it is the H flu that caused the influenza. Many years later, they discovered the flu virus, and then they realized, oh, it's not this bacteria, but the influenza virus caused the flu. But they left this name intact. So H flu, this is your bacteria. Some of the other typical bacteria is your Moraxella catarrhalis, Klebsiella pneumonia, your E. coli, and then you have a Staph aureus. Just so you know about a Staph, that a Staph is a very opportunistic bacteria. So this usually infect you when your immune system is weak. So this is more common after post-viral pneumonia. So post-viral pneumonia. So say for example, if you got a flu or COVID, so this virus actually weaken your immune system, and then if you get the bacteria after the viral infection, this is usually a staph mediated bacteria. So if you got a post-viral pneumonia, post-viral bacterial pneumonia, you got to cover a staph. And there are two kinds of them, as you probably know. One is the methicillin sensitive Staph aureus, and another one is your methicillin resistant MRSA Staph aureus. The methicillin sensitive one, this is the one that is most common. MRSA pneumonia is kind of less common, but these tend to be very sick. Patients usually are very sick. They are anytime when you see the patient who has a lung abscess or empyema, those are usually caused by the MRSA, just so you know. Okay, so these are some of the most common typical bacteria. Among atypical, the common one are your Mycoplasma pneumonia. Other one is your Chlamydia pneumonia. This chlamydia is different than the chlamydia that causes STD. That's the name is called Chlamydia trachomatis. Then you have a Legionella. So these are some of the most common atypical and typical bacteria, and there are a lot more that is out there that can cause pneumonia, but these are the most common one. Okay, so how these bacteria actually cause the pneumonia? So as you probably know, that pneumonia is the disease of lung parenchyma. So let's draw the structure of lung. You have this trachea. Okay, this trachea become bronchi, and you have on the right side you have 3 lobes, and on the left side you have this 2 lobes, and this bronchi forms something called alveoli that looks like this. And then here you have blood vessels. This is your blood vessels very close to alveoli, and you have this all kinds of blood cells including RBC, that is the hemoglobin in it, is circulating. So when you breathe in, so oxygen comes in when you breathe in, and this alveoli stretches, and this oxygen actually diffuses through the alveolar membrane and come into the blood vessels, where this is carried out by RBC that circulate throughout your body. Well, what happened is that when you get a bacteria in your lung, so say for example, if you get a streptococcal bacteria in your lung, and then you have this macrophage in the cell in the lung. This macrophage actually activate the immune response to clear this bacteria out. So when they activate the immune response, in doing so they release a lot of cytokines and proteins. And these cytokines recruit another inflammatory cells such as neutrophils. And this neutrophil release some more cytokine and some more protein in the alveoli. And these cytokine and protein in the alveoli called exudate. So your alveoli get filled with exudate. So then when you breathe in, when you try to breathe in, you get the oxygen here, but now that your alveoli is filled with exudate, you have a very hard time getting this oxygen passing through this exudate and then come to the blood vessels. So then this causes the difficulty in breathing, so-called dyspnea. And now you have a less oxygen coming to the blood vessels, so you have a hypoxia. And this exudate that is filled in your alveoli, this causes the sputum production. So you have now a sputum production, and on the chest X-ray, this exudate comes as an infiltrate. And when you check for the CBC, you will see the elevated WBC and neutrophils. And a lot of this inflammatory response also raises the body temperature, so you get a fever. So this is exactly what happened in pneumonia in simple terms. So what are some of the signs and symptoms of pneumonia? The sign and symptom. The most common one is your fever. Roughly 80% of the patient will have a fever. But fever is more common among young or healthy people. The older people, they usually don't have a fever, but they may have a confusion. They may have a chill. They may have a fatigue. They have like more non-respiratory symptoms in older people. Then they usually have a cough, or if someone has a chronic cough, then they will have a worsening of cough. As far as sputum goes, the patient, back in the day, just so you know, that the color of sputum people used to associate with a specific bacterial infection. So say for example, they thought that if it's a rusty color sputum, then you have this particular bacterial infection. But that is not entirely true at this time. What we know now, that you can get pneumonia with no sputum at all, or you can get pneumonia with clear sputum, or with yellow sputum, or with rusty sputum, or any other color of the sputum. So if you have a really bad yellow sputum production, that usually does make you feel that okay, this person probably have a pneumonia. But the lack of sputum production or the clear color sputum production, based on this basis, you cannot entirely rule out that this person does not have a pneumonia. So you can get pneumonia without a sputum, clear sputum, yellow sputum, rusty sputum, or any color of the sputum. Okay, other sign and symptom the patient will have is usually they have a chest pain, and this chest pain tend to be pleuritic in nature. So that means when you breathe in or breathe out, this chest pain get worse with breathing in or out. Some of the other will be dyspnea, difficulty in breathing. And in few patients, you may get sometimes the GI symptoms like abdominal pain, nausea, vomiting, diarrhea. Not very common, but you will find every now and then. So these are some of the most common signs and symptoms. Well, how about the physical exam? What you will find on the physical exam? Physical exam. The most common one that you will find that on the auscultation you will have an abnormal breath sound. So like they may have a crackle or ronchi or rail. This is the most common finding. Then they may have a tachypnea. As a matter of fact, tachypnea is a very sensitive marker for the pneumonia in elderly people. They may have a tachycardia. They may have a hypoxia. So these are some of the most common findings that you will notice on the physical exam. Well, just so you know, there is no specific sign or symptoms as well as physical exam finding that happen to be very sensitive or specific to pneumonia. Lot of these findings are also very common among many other cardiopulmonary diseases such as PE, pulmonary embolism, CHF, lung cancer, bronchitis, carditis, whether it's pericarditis or endocarditis. Lot of these medical conditions have a similar sign and symptoms and similar physical exam finding. Also, so you know that pneumonia is one of the most common differential diagnoses when we really don't know what's going on with the patient. And lot of time the patient who usually initially get diagnosed with pneumonia later on find out that they have something else. So definitely keep open mind when you are examining these patients. Okay, so after examination, how you will make a diagnosis? How you will make a diagnosis for pneumonia? Diagnosis. And the gold standard to make a diagnosis for pneumonia is that you will do chest X-ray and you will do the two view, PA and lateral, and you are looking for the infiltration on chest X-ray. Well, just so you know, back in the day, the appearance of the infiltration people used to correlate with a specific microbiological diagnosis. So, for example, if it was a lobar consolidation, people thought that that is kind of caused by the typical pneumonia. Well, that's not the case. But we know now that you cannot use the chest X-ray finding to make a microbiological diagnosis of pneumonia. It's just not possible. Okay, well, there are certain situations where patient may have a pneumonia and their chest X-ray may be negative, and this is one of the common one is your dehydration. If the patient is dehydrated, they may not have infiltration. They may be pneumonia. They may have pneumonia, or if the patient has patient are likely immunosuppressed. So keep that in mind. So sometimes you have to hydrate the patient and then you want to repeat the chest X-ray. So the negative chest X-ray does not entirely rule out that patient does not have a pneumonia. Okay, well, how about CT? Do we need the CT of the chest? CT chest. As you know, CT is more specific and sensitive for pneumonia, but you really don't need CT all the time in every patient. You need CT only in the high risk population group, and these are the if the patient is super sick or they have multiple comorbidities, and if their chest X-ray is either negative or if their chest X-ray is inconclusive. Inconclusive means that you have a patient who appear to be very sick. For example, they're hypoxic, O2 cells are like 88%, their vitals are 20,000, and you look at the chest X-ray and you see like this small little infiltrate, and you think like, you know, this small little infiltration does not explain why this patient is so sick. In that case, it's appropriate to do the chest CT. Or if the patient who has a multiple comorbidities and they look sick, they have abnormal vital signs, and the chest X is negative, in that case also it's appropriate to do the chest CT. But generally, you do not need the chest CT all the time. Okay, well, do we need another lab work for the pneumonia to make a diagnosis of pneumonia? So, this really depends on the patient that is in front of you. Generally, if the patient is healthy and they have a stable vital signs and you're planning on sending them home, you may not need any lab work. You can just stop at the chest x-ray, you find the pneumonia, you can start them on the antibiotic and send them home. However, if the patient is sick, have abnormal vital signs, or if they have multiple comorbidities, or if you are contemplating about admitting the patient or not, in that setting, it's appropriate to do some lab work. And some of the most common lab work that you will do is your CBC, and you are looking for elevated WBC, and they will have elevated neutrophil. Just so you know, the leukopenia, that is your WBC, less than 4,000, and thrombocytopenia, that is your platelet, less than 100,000, they tend to have a poor prognosis, poor outcome. So keep this in mind, poor prognosis. Then you will get the CMP, and here you are looking for the kidney function and electrolyte imbalance, and any new increase in BUN or any new increase in creatinine, this tend to have a poor prognosis, just so you know. So keep that in mind. If you have elevated LFTs, that tend to be the sign of sepsis. So keep this in mind. And pneumonia is one of the leading cause of sepsis. So if you are worried about sepsis, like the patient is tachycardic, hypotensive, then you may obtain lactic acid. We are looking for sepsis. Well, how about CRP? Usually it's elevated, but you may not need it. It does not add much in your management process. But sometimes your admitting doctor would like to get the CRP, mainly because they monitor the level of CRP as the patient condition improves. So sometimes you can draw it, but not always, not necessarily you need it. Well, how about procalcitonin? Procalcitonin. When this lab came, it was very popular at a time. The idea was if it's elevated, that means it will tell you that you have a bacterial infection. That's the one way to differentiate if it's a bacterial infection or not. Well, turn out over the time, people find that this usually does not add much in the pneumonia management. So now this is getting out of the favor. So if you draw it, it's okay. If not, no big deal. I rarely draw the procalcitonin. Okay. Well, how about blood culture? Do we need the blood culture? So this is the one that is very controversial, and there has been lot of debate about it, that if we need a blood culture or we don't need a blood culture. So let's talk about it. So there are pros and cons to this blood culture. The cons are that more than 60% of the time when you obtain the culture, nothing grows at all, no growth, more than 60% of the time. So then why do we need it? Other thing is that even if something grows in it, it's usually a strep pneumo and it does not change the pneumonia management. So then why do we need it? And sometimes it grows some contamination, and then when this contamination grows, you really don't know if it's a contamination or not, because you notice some growth, and then you start treating them. So patient ended up getting some over treatment that usually don't need it. So those are some of the cons. The pros are that, of course, if something grows on it, if it turns out positive, then you have a targeted therapy. And sometimes the hospital use this data to develop their own antibiogram. So it's very controversial. If you do want to obtain the blood culture, you want to obtain 2 sets and you want to get prior to starting any antibiotic. So the general rule at this time is this, that if you have a patient that you're planning on discharging home and you want to do the outpatient treatment, you do not need culture, no culture. On the other hand, if the patient is going to ICU, then you need a culture. If patient is going to medical floor, then it can go either or. You can draw it, you cannot. It really depends on your hospitalist, as well as if the patient has a multiple comorbidities, multi-lobar pneumonia, etc. So it can go either or. So that's a general rule of thumb. Okay. Any other lab value? Well, there's something called urine antigen test. Urine antigen test. It can look for the two bacteria so far we have, the strep pneumo, and Legionella. This is becoming very popular. It's not very common now, but you can basically get the urine and look for the strep pneumo and Legionella in the urine. But as I said, it's not getting very popular as of yet. So these are some of the most common lab work that you will do in the case of pneumonia management. Okay, then the next question is, where do you want to treat the patient? Outpatient treatment, outpatient versus inpatient, and how do you make a decision? Well, sometimes it's very simple. You look at the patient and you know it. Maybe patient is too sick and you're going to admit them, or it's not that sick at all and you're going to send them home. But sometimes it can be challenging. And so there are certain rules that will help you to make the decision. One among them is the O2 sat. O2 sat. If the O2 sats are less than 92% on room air or any decrease from the baseline, the 92% is the key here. Then in this case, you want to admit the patient. If the patient has a multi-lobar pneumonia, you want to admit the patient. Okay. Then there are some scoring mechanisms, thing that you can use that will also help you to make a diagnosis. One of them that I use very commonly is something called curb 65. This is a score. So curb stands for, C stands for confusion, U stands for uremia, that is BUN of more than 19, R stands for respiration, that is more than 30, and the B stands for blood pressure, that is your systolic less than 90 and diastolic less than 60. And 65 is just the age that is equal or more than 65. And you get 1 point for each. So confuse, so 1, 1, 1. So total of, you get a 5 point. Okay. And the rule is this: if the curve 65 score, you have a 0 or 1, you can send patient home, outpatient treatment. And 2 to 5, inpatient treatment. Okay. So this really helps you to make a decision. But just so you know, there is some major flaw in the curve 65. So for example, nowhere in the curve 65 they talk about O2 sat. So if, for example, a 40-year-old patient come to you with the O2 sats are like 88%, if you do the curve 65 score, it will be 0. So you cannot send them home. Another example will be if someone like 60-year-old patient who has a history of hypertension, their blood pressure usually run 140 systolic and today is 95 systolic. So if you do the curve 65, the score will be 0. You cannot send them home. So these scoring system usually kind of help you to make a decision, but you do not want to blindly follow this scoring system. The best way to do is that look at the patient, the vital signs, the lab value, and then make a decision. And then use this scoring mechanism, scoring system to kind of justify your decision. That's what I do. Okay. There's another scoring system is called port score, or pneumonia severity score is the same thing. I rarely use it, mainly because it's very complicated. There are 20 components in it, 20 of them. It's kind of too complicated, so I rarely use it. So curve 65 really helped me a lot. So other than this, you also want to have a low threshold and think twice for some of the high risk patients before sending them home. And these are some of the patients who are like homeless patient. You do want to admit the patient, this kind of patient, or the patient that you think they are non-compliant, or the IV drug user, or the patient who has uncontrolled diabetes, or if someone has multiple comorbidities. These patients, make sure to either you have a low threshold for admitting them, or maybe you may consider admitting them, mainly because they tend to be high risk group. Okay, so after this, let's talk about the treatment. How you're going to treat the community acquired pneumonia. So talk about treatment, and as we said, we will discuss the outpatient treatment. Outpatient. So all the medications that we will talk about today, those are the PO medication. Okay, so for the treatment of pneumonia, you got to cover both typical bacteria as well as atypical bacteria. You got to cover both. One of the best combination regimen available out there that cover both is your beta lactam antibiotic, your third generation cephalosporin, third generation cephalosporin, and this is your cefdinier. Any third generation cefdinier will work, 300 milligram BID for 5 days. This is one of the wonderful antibiotic that cover your typical bacteria. So you get the cefdinier plus you add azithromycin, or the so-called Z-pack. On day 1 you will take 500 milligram, and day 2 through 5 you take 250 milligram. That's once a day. So this will your cover atypical bacteria. This is a wonderful combination. If for some reason patient cannot tolerate the azithromycin, specifically if the one of the side effects of azithromycin is the QT prolongation, then you can use the doxycycline. 100 milligram BID for 5 days plus cefdinier. The alternative to cefdinier is that you can use the augmentin. This is a high strength, the high dose augmentin, that is your 2000 milligram twice a day for 5 days. So either augmentin plus Z-pack or doxy, or cefdinier plus Z-pack or doxy. These are a wonderful combination. It works really good. If you have a younger patient of less than 65 years of age, and if the patient has no comorbidities and healthy, in this case you can use just amoxicillin and 1000 milligram TID 3 times a day for 5 days, and plus either Z-pack or doxy. That's the other option. If for some reason patient cannot tolerate these, then you do have an option for monotherapy, and that is your levaquin. 750 milligram once a day daily for 5 days. So the levaquin is a wonderful drug. It covers both typical as well as atypical. It is a very simple regimen once a day, but it has a lot of side effects, including tendon rupture, QT prolongation, C. diff. So it has a lot of black box warning. So this is not your go-to drug. You start out with either cefdinier or doxy or Z-pack, and if the patient cannot tolerate it, then you can use the levaquin. And in all the treatment, the duration, as you notice that we talk about, is only 5 days. It used to be 7 to 10 days, but they found that 5 days really work. And you will notice the improvement in the patient's symptoms, improvement by between 48 to 72 hours. If you don't notice the improvement in 72 hours, then you do want to reanalyze your strategy to see something else going on. Okay. All right. Well, do we need the repeat chest X-ray? Usually not. In the outpatient setting, usually you don't need the repeat chest X-ray as long as patient symptoms are resolving and getting better. If the symptoms get worse, then you may consider it. Okay. One more thing is the steroid. Do we need a steroid in the outpatient treatment? And the answer is no. You do not need a steroid in the outpatient treatment. The people use steroid to manage the uncontrolled inflammation. So if the patient is really sick and they're admitted, and if you check for the CRP that is above 150, for example, in that case you may consider a steroid, but generally for the outpatient treatment you do not need it. So this is all about community acquired pneumonia and how to treat it. Hope you'll find it useful. Thank you very much, and I will see you.